Hello students, I am Dr. Mohamed Aslam, Assistant Professor, Department of Conservative Dentistry and Endodontics from Vinayaga Mission Sankaracharya Dental College. Today we are going to have a small discussion about the topic success versus failures in endodontics and the factors involved in understanding them. So we know that for every assessment of a success in RCT, we need to go through stages. So we will discuss this in stage 1 evaluation and stage 2 guidelines for successful RCT. Success in endodontics rests on a series of well planned and executed steps, beginning with proper diagnosis and ending with proper post endodontic restoration. So what are we trying to achieve in a good root canal treatment? We are trying to achieve highest possible level of comfort, function, longevity and aesthetics of the tooth and subsequent dentition. So what is the definition or meaning of success? It differs from person to person. If you are an insurance company or an agent, you are going to worry about the access to care, quality of care to be provided, cost and survival rate of that treatment, which is not very much in India, but yes, it is there in abroad. As a dentist, what is the definition of success? Elimination of disease, aesthetic enhancement and quality treatment which should be delivered. And what is a success for a patient? There should be no pain or disease, good function and aesthetics, and the treatment should be low cost. This is how they define success. So we'll come to the assessment of endodontic success. Normally as a dentist, what are we going to do? We are going to do clinical, radiographical and histological assessment. That is how we can evaluate whether a root canal treatment is successful or not. So what is the clinical criteria for success? It's an absence of pain, we all know, disappearance of sinus tract after root canal treatment, absence of swelling, absence of mobility, no evidence of soft tissue destruction and no loss of function. This is what we try to achieve by clinical success. How do we decide about radiographic evaluation of success? We should have a normal PDL width, or we can have a slight increase acceptable within limits, and we should have normal lamina dura and normal osseous trabeculae. And we should have a recall of follow-up of this root canal from 6 months to 2 years period. Only then we can define whether the treatment is successful or not. Histologic evaluation of success. This is the ultimate method, okay, to decide whether a root canal is successful or not. But unfortunately, we cannot apply that in real life because it needs biopsy or extraction. So this is only histological studies based. What does it say about a good root canal treatment? It says absence or mild inflammation, presence of periodontal fibers and good osseous apposition, and layering or repair with cementum over resected dentine and lack of resorption. If we achieve this criteria, we can call histologically it's a successful root canal treatment. And what is the success rate for RCT? Various studies are there, from Washington study to different studies. I am not going into the details. To be frank, if we are achieving 95% and above success, we have done a good job. Okay, though it differs. How do we assess failures now? Now that we read about success, we have to know about failures. So failures, we have pre-operative causes of failures, operative causes and post-operative causes, to be frank. So we'll go for pre-operative causes. How can we make judgmental error? Misdiagnosis. Yes, we can make misdiagnosis by misinterpretation of oral lesions, misinterpretation of anatomical landmarks and misinterpretation of pulpal pain and meaning referred pain. And there can be cases of improper case selection and even treatment planning which can end up in failure. So this is just a small example where you can see periodontal cyst, lateral periodontal cyst. I'll just show you here. I think you people can see it. So if the patient comes with pain, we have to assess the vitality of the tooth. If we miss vitality, we may end up doing RCT. So sometimes if it is lateral periodontal cyst, we don't need to do root canal treatment at all. Periodontal management is enough. Then misinterpretation of anatomical landmarks. Can you see this radiograph? In this radiograph, we can see the periapical lesion below premolar, which is crowned already with bridge. And naturally, if the patient says I am having discomfort or pain, we may assume that this is a periapical lesion. Okay, but honestly, when you take SLOB rule, shift angle radiograph, we can find that this lesion has shifted. So what does it suggest? It is a mental foramen which is overlapping there. Okay, so remember every time anatomical landmarks can be misinterpreted in radiographs. If you make a misinterpretation, we will end up in failures. Then improper case selection can lead to failures. For example, in this tooth we can all see there is a poor periodontal support. So don't take such cases. You are not going to improve the patient's condition. Operative causes. Can we cause failures in any operative causes? Yes. What are the failures? Failure due to anatomic variation, failures due to altered canal space. These are non-iatrogenic. Then there is iatrogenic, where we fail to achieve mechanical and biologic objectives. Non-iatrogenic causes means which I cannot control or you cannot control. This is complex pulp anatomy, okay, presence of extra canal, S-shape or C-shape canal, abnormal curvatures. You can see the pictures. So we have additional roots here. We have extremely curved canals. So these you need extra care. And failure due to altered canal space. Okay, when is the canal space altered? When you have canal calcifications like in this picture, or we have resorptions. We have a altered canal space which is difficult to clean, it is difficult to obturate. So we can expect failure in such cases unless we do our homework well. Okay, so iatrogenic causes. What are the iatrogenic causes? Meaning I, you or we, anybody can make a mistake. So we can happen from failure to achieve mechanical objectives by improper access cavity. For example, we can make an underextended access. If you make underextended access, you have a chance of missed canals. You can leave remaining remnant pulp there and limited instrument maneuverability. So you are not able to clean the pulp tissue properly. Next we have something called overextended access. You get over enthusiast, you cut a lot of tooth structure, automatically the tooth becomes weakened and it complicates the post endodontic restoration, and there is a very high chance of perforation if you overextend the access. Okay. Then other thing is root canal preparation. While I am doing BMP, I can cause ledging, perforation, transportation or canal blockage if I overzealous. I do preparation overzealous without following proper protocol. Then what are the causes where I fail to achieve biologic objective? If I fail to achieve biologic objectives, then it results in incomplete removal of irritants from canal, all due to the previous mechanical objectives. Okay, so if I don't follow them, then I will end up in leaving the remnants of pulp, which will be the cause of failure for my root canal. Then always remember, coronal leakage and apical leakage can cause recontamination, which means you should have a good filling after endodontics and you should have a good gutta-percha obturation at the apical seal. If both are not achieved, whatever good work you have done in a root canal, it can result in failure. And what are the post-operative causes? Can we get post-operative cause for failure? Yes. If we have a poorly designed final restoration and if you have improperly placed post, which can lead to perforation or fracture of tooth structure. Like you can see here, improperly placed angulated post, it can result in failure of a good root canal treatment. And then if there is no follow-up, where patient messes with the poor oral hygiene and recontamination happens, micro leakage happens, etc., etc. So now my second part of the lecture is how to avoid these failures or reduce their occurrence, and what are the important guidelines for a successful RCT. So we will go here one by one. So always remember, any case approach, any case sheet for any subject, we will be approaching review of patient's medical and dental history, check whether the patient is diabetic or cardiac, etc. They play a role in healing. Okay, so that's important. Then you know chief complaint and history of present illness. Listen to the history of listen to the chief complaint properly and address the history of present illness. Very, very important, because many times we find dentists attempting root canal treatment for some referred pain. Okay, could be sinusitis, could be neuralgia. It doesn't happen normal. Okay, so don't think everything is abnormal. First think normal. But if you don't have a proper clinical picture, you don't have a proper radiograph picture, go back to your history, reassess the history of present illness. Maybe you'll get a clue where you can find something new. Then third is objective clinical examination. Fourth, pulp diagnostic test and diagnostic radiograph. They are very important. Don't ignore them. Differential diagnosis and come to a final diagnosis as you are sure. Then you make a treatment plan and prognosis. Then documentation of entire course of treatment is needed. This is how we approach any case. So first thing I want to tell you about is step 1, beware about misdiagnosis. Okay, so always correlate history of present illness with clinical examination, radiograph and vitality test or other tests before concluding diagnosis. If you are not sure, reassess, go back to your table, take different radiographs. Now you have CBCT, you can do that, and just don't rely on technology. Go back to history, ask patients small questions, lead them to your diagnosis. Okay, next, referred pain like sinusitis often mimics acute pulpitis. You know this. So this radiograph OPG is taken from a textbook, and you can see there are multiple RCTs done on this patient. Okay, so phantomograph of a patient who has undergone several endodontic procedures without resolution of her complaint. So we should never end up like this. So we have to avoid misdiagnosis. For example, look at this case example. The initial radiograph implicated both 4.1 and 4.2 with periapic lesion. So if you look 4.1 and 4.2 both have periapic lesion. So how do we approach this case? We will say, okay, we will do 4.1 RCT, 4.2 if needed we will do re-RCT. No, you do pulp vitality testing. And doing pulp vitality testing, we saw that 4.1 was vital. So RCT was not needed for 4.1. Only 4.2 was done retreatment. Now you can see healing has started to happen. So a small vitality test, don't jump into radiographs. A small vitality test prevented RCT in 4.1, okay, and it was not needed at all. It was a misdiagnosis. Next, so what comes important? Study of radiographs. So they are most important in endodontics and equally misleading if not assessed well. And multiple angle radiographs sometimes are needed, and they should be reproducible to perfection, okay, and you should have knowledge of overlapping anatomical landmarks like maxillary sinus, mental foramen, etc. And radiographs can't tell diagnosis, so they only suggest radiolucencies and radioopacity. So don't even try to first, without seeing the patient or asking the history, don't see the radiograph directly. In fact, that will mislead you sometimes. So try to hold your urge to see the radiograph first. First ask what is the problem with the patient, chief complaint, then go for the clinical picture, then you compare with the radiograph. This is how you approach, but seldom we see that. I know many people, we just see the radiograph first and then we immediately tell it's RCT, no RCT, etc. But that may not be the chief complaint at that time, okay. Maybe that's a problem there in the radiograph, but that may not be the chief complaint, okay. So radiograph screening for the purpose of detecting disease before clinical examination should not be performed. So after clinical examination only you have to take radiograph, because I know there are some people who will tell, okay, go take OPG and come, then we will have a discussion. It doesn't work like that, okay, scientifically. And radiograph, only if you take multiple angle you will be able to appreciate if there is additional root like this, radix entomolaris. Otherwise we will never be able to judge with one single radiograph. Sometimes we will miss this in the radiograph. And we see whether the pulp chamber is calcified, how difficult is going to be this case. All that comes in this initial radiograph itself, okay. So if there is a fast break or sudden disappearance, for example, you can see here there is a big radiolucent canal, then suddenly it disappears. If such a thing happens, don't think it is always calcified. It can be calcified, but in some cases it will be splitting into two canals, like here, and you can see the obturation, okay. Similarly here also there is a fast break that leads to two canals. So try to learn this and try to read your RVG properly, okay. Your RVG has zoomed image, you know, have you used flashlight? You have flashlight image, you can add some notes. You have a working length, you can note it down in that. So you have a positive image, colorized image, you have, of course, you know, you have a ruler there and you have a revealer there. So you need to know how to use this properly, the tool with you, with a simple RVG. No need to go to CBCT every single time. With this itself we can achieve a proper diagnosis, okay. And these are the additional things I told you, embossed image, which will help you in detecting a root canal. A two-dimensional image though it will still help you. And of course current thing is cone beam CT or CBCT, whatever you can call, and this is a periapical radiograph of lower premolar. There is an associated radiolucency at the apex, okay. So obturation looks satisfactory, then why do we still have a lesion? So we had proceeded with CBCT of the same, and we found out that there is a missed buccal canal and an associated periapical lesion due to missed buccal canal, which was not appreciable in the initial radiograph. Next important step 3, which I tell everybody, is caries removal before access opening. So it's an important step but frequently overlooked. So most of the people are in a hurry to do root canal treatment, so they do the access opening, they don't bother about removal of caries, but that is wrong. So residual caries contaminates the root canal. So kindly remember, first remove the caries, make a proper wall, restore it with a temporary filling, then we need to place a rubber dam. Actually removal of caries will also help us in assessing the final restorability. You see this? So if you don't remove caries, later when you are removing caries, you will end up finding that you need post and core, etc. All this has to be planned before even you start the case. Okay, and if you leave the caries, when you are irrigating, you can find that irrigants go on the sides. Okay, so removal of caries is very, very important. And sometimes old restorative debris, like if you leave some amalgam, it falls down, the old restoration amalgam, you have not removed it fully, they go and block the root canal. Okay, and the soft leathery caries also can block the canals. So caries removal before access opening is a very, very, very important step. Next, no quality RCT can be done without restoring tooth free of caries. This is my message to you people. So you can see in this case how well it is clean. Then we build a wall. If you need, you can place a matrix. Then you go ahead with RCT. You don't do with caries. RCT start with the caries. Okay. It is not an option to remove caries, just remove it. Okay. Next, step 4, isolation. What are the important things in successful RCT? Isolation. No root canal treatment without isolation should be done. Unfortunately, we don't do in many places. I myself know, but in universities, colleges, yes, we do follow it meticulously. But I wish everybody follow that. Okay. And the best method is application of rubber dam. So rubber dam provides operator with a dry, clean field, infection control, and increase accessibility, improves properties of materials because there is less contamination from saliva, and improved visibility and less fogging. All this can be improved from operator side. From the patient related advantage, what are we going? This really, it gives comfort. We all assume that it's going to suffocate the patient, it's going to cause big trouble to the patient. No, 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 no. You just try this on patients. They really feel happy, they feel more safer with a rubber dam in place rather than opposite. Okay, and it prevents patients from swallowing or aspirating foreign bodies, you all know, and it also protects soft tissues by retracting them. So you are not injuring, you are not having a tension of injuring the tongue of the patient, etc., etc. Okay, so rubber dam is very important, and rubber dam is not a new thing. It's there. This is a picture of 1864 SC Barnum, taken from History of Dentistry textbook. It's a old thing. We have to implement still in some places. So next is access to success. So what is the next crucial step? We need to make a good straight line access, and we should know the alignment of the crown root. Crown is to root alignment, we should know. So Schilder in 1967 itself proposed access cavity design occupies the foundation of the structure and basis for each additional procedure, and accounts for approximately half of surface area, visually enforcing the importance of proper access. So you can see here in this, access becomes the foundation. If you have a good access, automatically you are reaching to a good canal preparation, which will help you finish with good obturation. So what is the most important landmark in access opening? A cusp, a groove, marginal ridge, crown angulation. It is simple, cemento enamel junction. Cement to enamel junction, yes. How is it important? You have to go to law of centrality. According to Krasner and Rankow, the pulp chamber of every tooth is in the center of the tooth at the level of CEJ. So the initial penetrating burr should be directed towards the center of CEJ. So you have to assume and look at the CEJ and find out and go to the center of CEJ. You will not perforate. Okay. Access should be initiated by mentally ignoring the clinical or restored crown of the tooth and looking beyond the mentally imaged CEJ. Next, the law of concentricity, it states that walls of the pulp chamber are concentric to the external outline of the tooth at the level of CEJ. This law of concentricity will help the clinician to extend his access properly. If there is a bulge in CEJ in any particular direction, the pulp chamber also will extend in that direction. So if you look at this radiograph, in the center you are placing your access cavity. Okay, so if it is mesiodistally wide, we have to shift to mesiodistally wide preparation. The next step is to determine the angulation of the tooth. Okay, this can be done by multiple use of radiographs and clinical observation. And the last tip before we start access opening to a general dentist point of view is to find out the cusp tip pulp floor distance, and the burr has to be set in the handpiece short of this length so that we don't go deep. Okay. So what is the conclusion? The conclusion I want to say is the internal anatomy of the pulp chamber dictates the ultimate outline form. So don't underestimate the anatomy of pulp chamber, they are very important. In some cases the access starting point can be even on a cusp. Let me show you the example. So this is a crown of mandibular premolar. It is tilted lingually relative to the root. So you can see this is there is a tilt. So in this case, access opening from the cusp is more sensible, where we will have a straight line access than we trying to enter it from this direction, then rechanging or ending up in perforation. Okay. So how do we know that we have finished all access cavity properly? Outline form should include all orifices, convenience form should be there for instrumentation, rotary, everything, and removal of remaining caries, dentin, and defective restoration should be done, and then cleansing of access cavity. When all these 4 are achieved, we know we have reached access cavity step properly. Next we will go one final example I will show you before I go to the next stage of cleaning and shaping. Access cavity, for example, look at this crown, it is not in the center of the tooth. So do you think it is a perforation? No. If you look here, it is not perforation. Why? Because this mandibular premolar was positioned distally before fabrication of FPD. So FPD overextended to the mesial by the laboratory to close the contact. So access is distally placed relative to the occlusal surface. So we know this, we do it, and we can use at this time cemento enamel junction as a guide, as I told you before. Okay. So unless it is in special circumstances like endodontic emergencies, do not do access opening through the crown. If micro leakage or secondary caries is suspected, the crown has to be removed to inspect the caries, assess the remaining tooth structure, and discuss the restorability with prosthodontist or yourself before starting an RCT. So don't do all cases through the crown. Okay, exceptions are there. Then next important point, apical stop or working length end point. Where do we stop our root canal treatment? So remember that the contents of the root canal should be removed and content should not go beyond the apex. That is very important. For this we need to have a proper working length which should end in minor diameter. So what is the minor diameter called in anatomical terms? Cemento-dentinal junction. So usually it is 0.5 to 1 mm short of anatomic apex. Sometimes it goes up to 2 mm in resorption cases. Except during scouting of the canal or apical trephination, do not violate the apical foramen, as you can transfer the contents of the root canal into the apex and cause periapical inflammation even if it was not existent before. So this step is very important. So what is the significance of a good apical stop? It determines how far in the canal the instruments are placed and work, determines how far into the canal debris and metabolites of the bacteria are removed, limits the depth of the canal filling, okay, and affects the degree of pain and discomfort the patient will feel, and avoid unnecessary inter or post appointment pain. So it's most important is this zone, okay, the minor diameter or cemento-dentinal junction. And when we have a young patient, we can go at the apex 0 to 0.5. For example, I have a 15-year-old, 20-year-old, I can go there. But if I am having a 60-year-old, 70-year-old, I can go for 1 mm short also, depending, because you can expect cementum deposition more, we can expect hypercementosis more on elderly patients. So there we don't go at the apex. So how are we going to take help? We are going to take help from naturally apex locator for working length determination. Apex locator is to be used in conjunction with radiographs. We cannot eliminate the need of apex locator. They are very helpful in such cases. Next, step 7, efficient cleaning and shaping. So I want to quote from Wien, Franklin Wien, what we remove from the pulp space is far more important than what we replace it with. Okay, so this is very important. And what are we trying to achieve by good cleaning and shaping? We are going to achieve biologic objectives and mechanical, 2 types of objectives. So biologic objectives, debride pulp tissue, debride bacteria, and remove the endotoxins. And mechanical objective, we have a continuously tapering canal which facilitates this debris removal easy, and we need to maintain the original canal anatomy, and we need to maintain the apical foramen position. So what are the very important things during cleaning and shaping? Always irrigate in a wet canal, not in a dry canal. And don't skip squeezes. Whatever rotary system you are using, if they have recommended sequence, kindly follow the sequence, or if you are still using hand filing, you have to follow proper recapitulation method. Okay, so and using rotary, we have to have a light touch or pecking motion. Okay, don't push aggressively, and don't force or bind anything, hand file or rotary file. And the pre-curve hand instruments, whenever you are having a struggle or you are having a curved canal, always pre-curve hand instruments, use them and then use rotary again. Okay, so as I told you before, recapitulation is very important if you don't want to get stuck. Then pre-flaring helps. Okay, so if you pre-flare with gauge drill or SX file as in ProTaper, it will help you continue in the middle third and apical 1/3 cleaning and shaping. Then regularly clean the flutes of the files to clear the debris, otherwise you are going to spend more time and not be efficient cutting. So what is the most important thing here I want to say? Partial pulp extirpation is unacceptable. So we have to remove almost all the pulp tissue. Next, while doing cleaning and shaping, always remember, if you have a curved canal, always try to read about balance force technique, or I will give you in short, cut on the inner wall. If you cut on the inner wall, you are still maintaining the canal curvature. If you cut on the outer wall, you will be zipping out. Okay. Curved files help turn around to original canal. Use nice night-eye files, okay, even hand files, okay. And you should know irrigation depth. Your irrigation depth during the final stages should be near the apical delta. Only then you have done a sufficient cleaning and shaping. Next, we all know about intracanal medicament. They are very important. I will not go into detail of this. We all know calcium hydroxide, chlorhexidine, combinations of antibiotics. We have eugenol, pharmacrosol, steroids. I just want to highlight one thing: the phenols and aldehydes, they destroy host tissue. They are toxic. Nowadays they are not in use. So if you use too much of phenols and aldehydes, and they can cause periradicular infection. Okay, so they are not advisable. Next, I want to give one small tip about antibiotics and the treatment of endodontic infection. If you are planning to give antibiotics, the patient should or may have fever, malaise, lymphadenopathy, trismus, increased swelling, cellulitis, osteomyelitis, and persistent infection. If you find a teeth with necrotic pulps and a radiolucency, you don't need to give antibiotic. Okay. Likewise, if there is local fluctuant swelling, you don't need to give antibiotic unless you find the patient medically compromised, where you need to supplement the antibiotic because of immunity, lower immunity threshold for them. Okay. In a normal persons, you don't need these conditions. You need these conditions. You don't need. You can look at this slide. And towards the end, step 9, obturation. Hurry to obturate. That's the line I want to tell. There is no advantage of multiple visit RCT over single visit RCT nowadays due to advanced rotary instruments. Okay. So removal of smear layer is definitely recommended, and obturate as soon as the canal is clean. And the sealer application and consistency is very important. Don't underestimate your sealer consistency. And contents gutta-perca, whatever your method, thermoplastize, additional system B, whichever system you use it. Okay. So one small tip I want to tell you: incomplete obturation is the most frequent cause of failure. Up to 60% cases failed in Washington study. Debris left enough, it can cause a persistent infection. And overextended obturation, they are the most frequent cause of post-operative pain, and debris pushed outside can start a new periapical lesion, and cemented repair is lost. That also is not recommended. Always remember, teeth with root canal filling 0 to 2 mm from the root apex showed significantly better periradicular conditions than teeth with either over fillings or under fillings. So try to reach the apex within 0 to 2. Of course, we have to achieve 0 to 0.5. It depends patient to patient, and you use apex locator. Last step, immediate coronal seal and post endo restoration. Coronal seal is the most important to avoid recontamination. This should happen even during your intra-appointment dressing. You place a temporary filling, you make sure you have done a good temporary filling. Otherwise, you will have reinfection very easily. Okay, and go ahead with post endodontic restoration and crown as soon as possible. There is no specific time. Once it's asymptomatic, you can go ahead. Okay. So in summary, a dentist should equip himself with the skill, with the help of his knowledge, and have a knowledge about recent advances. Okay. And that will help him in deal with patients who are medically compromised or with difficult anatomy or quality care. So I give you the following references here. And then in conclusion, I always say RCT should never be going into 9th sitting and then referred to surgery for extraction. If we follow all these proper steps meticulously and not fall into the trap, we can do a successful RCT with predictable success. Okay, and thank you for listening to this video. Thank you very much.